I have clinics in St. Louis that treat between 400 and 700 heroin addicts a month. And I have been in this field for almost 30 years. I believe that addictive disorders is one of the few chronic conditions that throws the patient into a state of survival. Think about the Maslow's pyramid being inverted. We are trying to treat, so it throws them into a state of homelessness. And when you're homeless, you get desperate. We are treating the problem with the rest. Homelessness cannot be treated with a soup kitchen and a shelter. That's exactly what we are doing. The problem is that our treatment model that we offer is a business model that was okay 60 years ago. For the first time in history, we are dealing with addictions. We have not had any strategy to control the supply of opiates. It is getting more potent, it's getting more toxic. So in my clinic, for instance, I see buprenorphine is seen as a form of currency. These are not bad people, but they're desperate. We don't do anything more than that, just giving them buprenorphine. They see naltrexone or Vivitrol as a form of punishment when they can get opiates everywhere. We need to radically change the whole method. Otherwise, how else can we explain that there are 25 million people affected by drugs and alcohol, and all we have is 5 medications to treat them, and less than 10% get any medications? I would like any of you to jump in this and say, why is this state of affairs where the entire field is so deeply stigmatized?
All right, there we go. So there's not one field, right? There is the field of abstinence-based treatment programs that are inpatient, and they really don't talk with opioid treatment programs, which is actually its own field as well. And they have their own national meetings and their own collection of journals. Then you have the American Society of Addiction Medicine side, which is a multidisciplinary specialty that's now ABMS certified, and they're more medicalizing it, and I would be a part. I'm the chair of the Legislative Advocacy Committee for ASAM, so that's kind of the arm I came up in. And then we have the AAAP, the American Academy of Addiction Psychiatry, and they actually have their own national meeting and connection and journal. So there is not really a field of addiction medicine to coalesce around, and right now we're still in a place where there's infighting, where we haven't decided on what are the outcome measures that we should use, what are the performance measures, what is a good program versus a bad program. We need places like Washington University that has this deep bench science to want to own this topic. I mean, we have a lot of people doing cancer research, and that's awesome. We have a lot of people, doing research on Alzheimer's and, and this, and that's great. But we have very few renowned places owning this disease. And until we have, neuroscientists and physiologists and all of these people deciding this is the disease we're going to work on as our life's work, then we're going to be stuck in this 4 fields approach because we're not going to be able to coalesce on a message.
That's our silos.
Yeah, well, there are even more silos. It's not just a silo. It's like with a brick wall followed by tanks, followed by, angry minions.
In the recovery world meetings, not a lot of people know about buprenorphine. And when I first started talking about it at the meeting, I was blessed enough to have a doctor who could prescribe this and who believed in it long term as well. I don't think that's the common mark. And at first, when I told the recovery groups that I was doing it, some of the old timers and just a few different groups basically declared that I wasn't sober because I was doing that, So I stopped talking about it for a short bit, and then I thought, you know what? I'm bipolar, I take my medicine, I live okay for that reason. I'm in recovery from addiction, I take my medicine, and I am not a live person walking around dead anymore. I'm living life for that reason. And people need to know there's many choices. And it's not about just taking the medicine. Buprenorphine gave me a fighting chance to follow through with the recovery groups and my psychologist and psychiatrist. And, it takes a whole bunch of things to do it. But that gave me the fighting chance I needed to go forward with it all.
Good. So I'd like to know if buprenorphine is essentially the best silver bullet we have right now, what's the rationale of having so few doctors certified, or the limit on certification, why they can treat so few patients, and also what's being done, what's the latest on changing that policy? Because it seems like that's a major barrier.
I'll start off speaking to that. We have 20,000 physicians in Missouri. 60% of them practice in 3 counties. So that's an issue. And the second issue, we only have 400 waivered physicians in Missouri. I'm one of them. I'm licensed and have my buprenorphine waiver. So one of the governor's initiatives is to increase the number of physicians waivered. And so we're going to be very purposeful about that. I'll let Rachel and others speak about their efforts in that arena as well. And Rachel may want to speak to even, we submitted to the president last week some suggestions she had about that through Jerome Adams, the Surgeon General, who's a friend of mine.
Thanks. I mean, you're absolutely right. The limits are bogus. We don't have patient limits for OxyContin, right? Without getting too far afield, I think they're there because of politics, because of reasons, because people were scared and they put them there. But absolutely, I think we should push as a community to eliminate the requirement for a waiver altogether. Or even if they insist on keeping the requirement, then why do you have to start at 30 patients and only extend to 100 after a year? That's crazy, right? 30 patients is nothing. You could treat a lot more. Okay, the other side of this coin, though, and an argument that I heard some smart people make, so now I'm going to copy it, is maybe we shouldn't be talking about patient limits at all, because it just further entrenches this belief that it's a separate thing that people need to do and that some people are going to do most of it. Instead, if every physician that we had a caseload of 10 patients, right, that wouldn't be hugely burdensome on this, but it would really close our treatment gap. So I do think they should get rid of the limits and the waiver requirement. At the same time, that shouldn't stop us from more people doing it and just maybe sharing the load a little more.
And I think there's still a significant work we have to do, just physician education. So when you look at how we teach this in med school and kind of how people learn in residency, these aren't the people that people want to take care of. This is the room that's avoided in the hospital that maybe one person goes in because no one wants to deal with them. And so then when you're going out in your private practice and you're like, hey, let's take care of more of these people, no one wants to do it. And then you still have these old rumors about law enforcement and all those other things. So I think we slowly have to chip away showing that, that those perceptions and ideas are just incorrect, and that this is something that all physicians can do and do successfully, and that you can treat these patients, and they're incredibly warm, incredibly helpful, and once you help them get turned around and back to where they really want to go, it's really a great experience.
First, thank you, everyone. As a new intern here, I'm thankful to actually have been part of an undergraduate medical education elsewhere that incorporated a lot of this. It taught me that all of this is approached through the chronic disease model, that we should not withhold medical assistant therapy, multidisciplinary therapy, any more than we would not give insulin to a diabetic. My question, though, as a relatively newly minted, emergency medicine intern, is there's still this missing link. I'm in the ED, and we have the ability to prescribe naloxone and this, but what is this link where I can take a patient that is coming in who I know I can identify opioid addiction, but I don't know how to plug them into those resources. You know, I feel like the resources of in the moment when someone's in the ED, which is the intake point for these issues, for social issues, for the social determinants of health, for opioid addiction, how do I take that moment that I have, first point of contact for these patients, and get them to the treatment that has evidence behind it?
So this is what I do for basically a living now, is try to go around in communities and develop these ecosystems of care so that there is kind of the no wrong door approach. And the no wrong door means if you show up anywhere that, whether it's EMS, whether it's a hospital, whether it's a primary care office, an OBGYN, you just delivered a baby, you know, all of these things, that it's not just a sheet of paper with a bunch of phone numbers on it. So each community at this point in time has to do an environmental scan. So you have to evaluate. So we have this thing in addiction called the ASAM criteria, which are the levels of care that can be delivered to patients with addiction. And they're significant based in science. There's actually an online platform where you answer a bunch of questions and it tells you what level of care they should go to. It's independent and as far as the evaluative process, but nobody uses that. But if you in an environment, I mean, actually a lot of states have mandated using that, but it's not thought about in an emergency department. Like, where do I send them? Because we need to make sure that we not only send them to treatment, but to the right level of treatment that they need for the severity of their illness, just like we would decide between OBS, inpatient, or ICU. I mean, we have that algorithm down for every other disease. Well, that algorithm actually exists for addiction treatment. But it starts with the environmental scan of your community to determine which of those levels do you actually have. And that means that somebody has to go out. We just did this in Camden, and so I went and visited everyone who said they treat addiction. And almost in fact, no one actually met the level of care that they said they delivered on the piece of paper. Not one of the programs actually met by the letter of that curriculum. So you have to first do a rock solid evaluation of what you have available in your community and whether or not they use evidence-based as determined based on what we talked about today. And at that point, you can decide where your gaps and barriers are and start to build out those pieces. But I'll tell you right now, your best link is the social worker in the emergency department, because this is the person who generally knows all of those current things as best they can. I used to think they were like the unicorn. They were just like magic, right? I put in the referral for a social worker, and then my patient would just disappear somewhere, and they were magic. But there's actually a lot that goes in to what they do and how they do it. So definitely combine with them for the short term, but big term, it takes work.
From an EMS perspective, I would say in addition to the magical social worker that we all know and love, better integration with the emergency medical services is important in this. We have recognized from a time-critical diagnosis perspective that matching the right patient with the right care and the right time works for stroke and STEMI and trauma, but we can apply some of those same principles. One of the first medical encounters for many of these patients is that EMS provider that extends our doors out into their communities and out into their homes. And so they are our eyes and ears as physicians are making house calls daily on these patients. So improving the communication and the infrastructure for allowing our EMS to be a part of this with us, I believe is important.
The Behavioral Health Network of Greater St. Louis runs a project called Project EPIC, which is funded by our STR grant. And they're based in BJH and a number of other hospitals in St. Louis. And the idea there is to intervene post-overdose, have dispatch and peer recovery support specialists to the ED, and have that person sit with the overdose survivor and their family and engage them in motivational interviewing, give them overdose education, and hand them naloxone, and then connect them with treatment. It works best when buprenorphine is inducted in the hospital. You see better rates of people making that leap from hospital to treatment. But more projects like that need to happen, or not more projects, but more buy-in into these projects. And ideally, each ED would have their own sort of addiction consult, social worker, whatever team who's really tapped into those community resources and new projects like this, because I think a big problem we have is that a lot of these projects exist, but people don't know about them. So this exists at BJH, and you guys are readily referring people to community care after overdose, and it's working. So talk to Evan Schwartz if you want to get on that.
Ultimately, where we're headed as a state is that we know we only have 400 psychiatrists in the whole state. And so what we hope to do is to build out our primary care network. We again feel like that when we look at behavioral health issues, in North Carolina at any given time, a third of ER beds are filled by involuntary commitments. And I probably think that's probably similar here in Missouri. I haven't been able to find that statistic. And so we need this concept of a medical home throughout the state. We need primary care doctors who are more comfortable prescribing buprenorphine or to take care of behavioral health issues, because we're not going to be able to turn out enough psychiatrists. So my hope would be by the time, I've lost where you are, you finish your education, that we will have in place. And the reason we're hopeful for that is we pay for it. We pay $120 million every year between us and the federal government for all graduate medical education in Missouri. So we will shift our emphasis from training specialists and put them more on turning out primary care doctors, if for no other reason to put more physicians in the 112 counties that only have 40% of the doctors in Missouri now.
Thank you. First of all, I want to say a heartfelt thank you to all the speakers for making my prediction come true. I spent yesterday chasing the eclipse with one of the first-year residents. I told them that if you fail to miss any conference this year, it should be this one, because this is going to be one of the best ones of the year. So all credit to all the speakers for making this fulfill my expectations, and I'm sure lots of other people's too. So first of all, well done. And I'm going to, first of all, my question address the countywide prescription drug monitoring program that's been created here. And thank you, Representative Reeder, for doing your best to try to get a good bill through the legislature. But what we have now at the county level is a physician-created tool to, in an evidence-based scientific fashion, address a medical problem free of being polluted by the vagaries of the legislative process to deliver evidence-based care to our patients. So Dr. Williams, I'm asking you if you would be so kind as to pledge in front of the group here that you'll do all in your power to try to persuade the legislature and to Governor Greitens not to let the state legislature crush our PDMP the way they crushed the Fight for 15 initiative regarding minimum wage here in St. Louis County.
Well, certainly, thank you for your question. And again, please understand, we support as a state the voluntary PDMPs. We have incredible appreciation of what's been done at the county level. Again, I don't know how often I can say it, but I'm willing to go speak to any county or city that's considering a PDMP. I've used a PDMP as a practicing physician, but here's the rub. We think that our efforts, if we can develop them, will support voluntary PDMPs, because the holy grail here is to have a PDMP that doctors will use. Absolutely. And that's not the case in the United States right now. Again, the CDC does not recommend voluntary PDMPs because nationally they're only used by a very small percentage of physicians. And again, so what we want to do is to build out our voluntary PDMPs. So nothing would make me happier than for Representative Rader and I and Steve and others to go around to every county and get that in place. But where we want to get is to use this sophisticated data analytics so that when I, who practice with one, sit down, I don't have to remember another password, I don't have to go into another thing, that it's integrated into a confidential electronic medical record so that I can literally look at you as you come in, just as you had a penicillin allergy, and go, oh my gosh, you're on 300 equivalents of morphine, and that we know, based on CDC data, at that rate, you have a tremendous chance a year from now, so that would launch a conversation in real time between you and me about going, gosh, you're on a lot of morphine equivalents. Where are you getting that, and what is that about? So we clearly see what we're doing is complementary and in no way competitive. Now, with the General Assembly, that goes back to 7 years. I looked at it yesterday, I think. And so we will continue to push in the General Assembly for voluntary PDMPs through the governor's office.
Yes, and one of the things that we've been doing is I've been working since session ended to help get this passed in all of the counties across the state, the St. Louis County version, to get them to add into that, because it's a very robust program, and it gets us where it gets us a great program. Now, what I have seen more positive results from is when the medical community gets involved. And that's one of the things that helped us down in my area and then also in Southwest Missouri is we really got the health department, we really got the medical community, the physicians, and the pharmacists to start reaching out to their commissioners and to really start demanding that they pass this on a local level because it's inexpensive. It's, I think the cost is $7 per end user for any physician that wants to use it, and for the pharmacists that are required. And so it's very inexpensive to be able to give that clinical tool to the medical professionals to look that up. And so I think that we have an excellent start. We're trying to get to 80% by the end of the year, and I think that if we get to 80% of Missouri's population by the end of the year, that will drastically change the conversation in the legislature come January. But in no way do I want to go with a less robust program. I think that there are things that we can improve upon, but I think that we definitely want to keep this basic, robust program for the entire state.
So from a federal level, I think it's important to understand that the reason we don't have a national PDMP is Missouri. Very specific. I mean, I'm in DC all the time, and we work on this, and we've worked on it from a bunch of different angles. And before you can make a national policy that starts to dip into pharmacy numbers from every state, because there are people that may get their medication in Kansas and come across and live here, until you impact someone in a state that doesn't have it, nobody wants to touch that. They already have legislation built for a national PDMP, and what's nice about that is that Epic and Cerner and Allscripts, they can actually start to build macros that will put that in there instead of having to do it for every one-off PDMP, which is why they haven't started building I mean, they have started, but they're not robust as to what you spoke to. So when we talk with the CEOs of Epic and Cerner and this, they're like, the minute we have a national PDMP is the time in which we will absolutely take the time to embed it in our electronic medical record, because it will be pulled down from a single entity with a single set of federal regulations, because them trying to figure out, well, what if you have a provider that does home care and crosses a state line on a laptop and tries to go to a PDMP? I mean, that's a violation for some of the PDMP rules. And so there's a lot of little idiosyncrasies when it's done at the state base, but the federal government, even if all the counties signed on to the county base, it's not going to change the fact that the state doesn't have a legislative pathway toward a regulation that allows for a PDMP to exist at the state. So even if you had 100% of your people, but it was through a county pathway, it still wouldn't impact our capability to create a national database. That would be up to the states, and most states actually, not most, I would say 23 states as of last week have mandated the utilization at the initial prescription and every 90 days after for continued prescription. I mean, I live in the most highly regulated state for this stuff in New Jersey, where the first script can only be for 5 days. And you have to take extra education, and you have to check a PDMP. That has changed behavior significantly, and it's frustrating that we've lost the power as providers to make these decisions for ourselves. But opioid overdose is the #1 cause of injury-related death in the country, and we caused it. So we kind of lost that capability, and it now has to fall to regulators.
So my question is primarily for Dr. Waller. One of the things you touched on is the naltrexone treatment pathway, and unfortunately, I've been doing some reading that there are certain areas where the court system is starting to specifically prefer the naltrexone naloxone pathway, specifically because it appeals to their instinct of treating it as a punishment, as a blockade of the opiate receptor on a metaphorical level, rather than what some people incorrectly feel is continued reward on the medical treatment level with Suboxone. I question, you talked about a subpopulation of people for whom the naltrexone naloxone pathway might actually be the best one. In the absence of widespread ability to functional MRI imaging and micropipetting for human brains, how do you identify those people who have a high enough level of dopamine, say, that they might benefit from that pathway?
Yeah, so to the first part of your question, I think we've all created our own narrative about what the criminal justice system wants and doesn't want. What they really do want is these people not to come back to jail. And they feel pretty powerless, to take a little bit of their side, is they really want to do the right thing. And it's not necessarily for punishment, it's frustration. Because we as the medical community have not helped them at all. We put up this barrier of 42 CFR Part 2, and we use it as a wall to not have to give them any information about our patients. And we've created this narrative that it's always bad. Now, to that, I have sued a judge for practicing medicine without a license. and they didn't allow it to go to court. They just changed to our care plan. There is this overview. It's weird to have a drug that's actually pushed on a non-medical place. So that's an interesting thing that has recently happened with this drug. But the way that you recognize it is through some short-term interaction with him. You can start to ask basic questions. And what you're trying to get at is, do they naturally produce dopamine? Do they naturally have motivation? And you ask them, what do you feel like Monday morning? I mean, that's where we start. How's it like kind of getting up and going? You can kind of get an idea of how hard is it to really start compared to most people. You know, and if they have kids, what makes you happy? And have them kind of walk through the things that make them happy. And then you can poke at it a little bit, because most of the time they're going to say things that they know you want to hear. And you can say very specifically, I know you know how to act to look happy, but are you really happy? Because anhedonic depression, which is this low dopamine depression, is a profound empty sadness. It's not a cry in the corner depression like would be low serotonin or norepinephrine. It is a flat affected, I don't care, I just want $100. Okay, whatever. My kid just got something cool. Okay, I'm gonna lose my house. Okay. It doesn't matter. It's this flat affected depression that doesn't have the normal ups and downs. So you look for those people who, in a normal day, do they have normal frustrations, normal happiness, normal patterns of motivation? And those are the patients who would do well. Now, because it's hard to tell that at the beginning, the default should generally not be that based on the current level of data. The default should be buprenorphine or methadone. And it took me a few years of doing this to really have a few people that I would use that as first line. But with the criminal justice piece, I get people that have already been given it, and I have a pretty good indication on their first visit whether or not that's what we're going to continue, or if we're going to move them over to buprenorphine or methadone.
From an EMS perspective, I think it's interesting that you bring up the punitive aspects, because in the first responder world, the risks of the punitive behaviors is very high. You've given these folks one tool which can put people into immediate withdrawal, and then when they're angry with that first encounter with the medical system, you hand them a piece of paper that says, you don't have to go to the emergency department. You can make the decision. They don't do anything for me anyway. And then the EMS crew drives off and says, well, we saved their life again. But what we're finding with the community paramedicine programs is when you give these folks, these frustrated providers, a different medical tool that is more effective, you can chip away at some of that dissociation, which is kind of a psychological barrier that the first responders use in order to cope with the failures. And when you give them the right tools, sometimes you can chip away at some of that, and it becomes less punitive and more healing-centric.
Dustin Smith, I'm one of the community ER doctors, and I came here today because I've met Evan in the past during training down in Dallas, and I just wanted to thank him and all the panel members for setting this up today, and also for him being a resource for the residents. I feel like we're much easier, or it makes it much easier to use a medication when we've had that experience of the safety net of residency to get the experience before we're just out in the public and trying to use a medication for the first time. I promise I am not a plant in the crowd, but Dr. Winograd's statements could not be more true. We don't have to worry about treating 30 patients. We need to focus on maybe how we can even reduce our own burnout by being involved in a process like this, taking us out of the ER. I think ER docs are ideal for addressing this issue and getting involved in the community, and maybe starting with 2, 4, 10 patients once a month, once a quarter, to make it a positive impact. I'm making that statement because I actually just went through the ASAM training, just received my waiver training in the mail last week. I'm here because of Dr. Waller's lectures. I think you've all witnessed today. He's an amazing speaker. And after I went through that training, I said, do I have to go to New Jersey to meet this guy? And then all of a sudden he's here speaking to us today. So I think we all have an amazing opportunity not only to start using this in our practice, but also doing the training. I believe you get CME from doing the training as well. And I don't know about everyone else here. Doing the same trauma and cardiac CME every year gets a little redundant, and I think this is an opportunity for us to learn more and to communicate with our colleagues about how we can be an effect for change. So thank you all for being here. The quick question that I had for the state of Missouri, for the representatives, and Dr. Williams, thanks for the phone number, by the way. I am going to call you. Number one, has there been any state-level initiative to address the fact that physicians, community physicians, have employment agreements that require them to hit certain satisfaction scores? And the fact that oftentimes the two things that are being addressed in community hospitals are we updating our patients and are we controlling their pain, which instantly drives opiates into the hands of people who objectively have pain scores that do not require strong medicines? And then the second question is, what are we doing to be ahead of the curve? Let's say these efforts from the governor and the state to take out the pill mills and take out the individuals who are recklessly prescribing medications, what are we doing to stay ahead of that curve so that we don't have an influx of even more heroin when those resources are taken away?
Yeah, good questions. The first one, again, well, I'll go to the last one first, and that is that, we obviously have a very strong concern that if we don't couple our efforts to reduce the supply of oral opioids, that people may get driven to heroin. So you have to always be very sensitive to that, and there's been some evidence in other states that that may in fact have happened. So again, we believe very fervently that you have to have an integrated, comprehensive, coordinated approach in these issues, or you create additional problems. And so I think it's that. As far as community physicians, again, we think they are kind of the linchpin of where we're headed with this. And what was your specific question about?
The first question was in regards to patient satisfaction scores.
Yeah, right. Thank you So yeah, we feel very strongly about that. As I tell people all the time, having practiced for 30 years, it is 98% doctors don't get up every day going, gee, I wrote 30 opioids yesterday. I bet you I could write 40 today if I really work at it. 80% of all the oral opioids used in the world are used in the United States. I work all over the world. And in other countries that I'm involved with, after a hysterectomy, you don't write for Lortab. They don't even know what I'm talking about. They write for Motrin and Tylenol. And they just find it fascinating, like I'm come up with this new something that you go, you do what? And that's literally a wide swath of countries. So we think certainly a large part of this that I think was spoken to by the panel is changing societal expectations. In the legislature in the last session, we actually had introduced a bill that would prohibit your evaluations being based on pain scores. And CMS is going to do that, I think, in 2018. That didn't get a lot of traction, but clearly I was in Douglas County, and even the EMS trucks, they sent out a survey like 2 days later going, how was your ride to the hospital? And one of the questions was, did they give you pain medication? And if you don't do it, you get dinged. So we're incredibly sensitive to the idea that most physicians are not they're not the problem. They are responding to a culture, and culture comes from our word cultivate, to grow, that this has been a phenomenon that has grown in our country, and Sam Kianonis talks about that in Dreamland, where we have created this perception, unlike the other 6.87 billion people on the planet, that pain has to be treated to its complete cessation with whatever it takes. Another bill we had in the legislature that didn't go was that we think that when you prescribe opioids, it would probably make sense to describe the risk and benefits of that just as you would for surgery. To say, okay, here, I'm going to give you these 90, pills or whatever if you don't have limitations, but let me tell you what the risk of this is. That there is a certain cohort that's been very eloquently explained today that we may not be able to predict, that this may be the worst thing we could ever do for you, and you need to be aware of the limitation of our ability to predict who that is.
Yes, and I would like to add to that. So the patient satisfactory surveys, in the House, we discussed it at length, and we think that those are a huge part of the problem. And so we intend to continue trying to address that this next session. And I think that we have enough buy-in from the Senate as well, because that is something that we have identified for a long time now that that's a problem. I think the problem that we had in the past was that we had a physician trying to express that, And so, you know, it looked a little, and people weren't listening. And so now we have more that are willing to discuss that. And so I think that we're going to be able to get there for sure. I believe it's a huge part of the problem.
So first, thanks for trying to push forward that legislation. I'd say maybe one thing to give you some hope, there is a study that was done a couple of years ago that kind of looked at this, and it was one location, a single study, and they actually looked at patient satisfaction compared to people that got opioids and that didn't get opioids, and they found it to be just about the same. Now, I'm sure there were many other confounders in there and explanations that were given to the patients, and once again, it was only one center, but there may be some optimism in there that just because we're not giving opioids, patients just aren't going to be all upset with us. Two, as far as the community approach, things that Rachel's doing, so she set up throughout the state where you for free can get licensed and waived, and in addition, follow-up programs where you can actually learn more about actually treating addiction medicine. And I'd say, just as an example, actually Dustin's a great example. So he's an emergency physician, but himself and I think some compatriots are actually setting up their own addiction clinic in that area because they saw a need for it to help their patients. So he's a great model to follow.
Really quick note on the PDMP. So I think it's good to remember when we're talking about PDMPs that when we just throw that phrase around, we're really talking about a database, right? And it's what you do with that. So I really appreciated what you said, Representative Rader, about how it's a clinical tool, and we can't lose sight of that, and we need to always play the tape all the way through. So absolutely, an uptick in heroin deaths is certainly a risk. We've seen it in other states. We need to be very careful and intentional and tactful about when we cut a physician out of circulation, what do we do with all those patients who are dependent? And I was talking with Corey before this about some really cool creative stuff they did up north, and we need to do that to also like give warnings to OTPs and increase their caseload, make emergency waivers available. You're like, what are we gonna do with all these people? And I get very nervous when, and I've said as much to the people on this panel, I get very nervous when we talk about enacting PDMPs when we don't have those things in place.
So first of all, I wanted to say thank you all so much for coming, and thank you for Dr. Ruoff and Darlene for resourcing this to make it happen. Thank you very much. Additionally, Shannon, I wanted to really commend you because I know that it has taken a lot of strength to get up and talk in front of a bunch of white coats. You know, so thank you very much for putting yourself out there in a very vulnerable way to give us a face to the problem, so thank you. We've done a lot of talk, and I just want to take it down right now to what we actually see. And we've talked a lot about it, but let's summarize. I get a patient who comes in, and I know that there is a drug abuse problem. And I talk with them, hey, the past doesn't equal the future. You have the ability to change this. Great thing about history, every day you get to create a new one. Yes, I want to do that. I want to do that. You call social work. Social work comes in. They very diligently give them their paper list of telephone numbers to call. And maybe they can get in 2 weeks. We've already lost before we've started. I am happy, and I will pledge now that I'll get my licensing done. I'm glad to hear about maybe a commitment from EMS. This is a stopgap measure. This is not sustainable, especially in a system where these patients are not resourced. Because when they do not have an outpatient place to go, they will continue to come to the emergency department, and we will take care of them because that is what we do. But it is an unsustainable model. And what I'd like to hear from you all is the hope. What can you tell us that you can do or we can partner with you to do? Specifics, action items that will change that so that this is not a Band-Aid to cover up the partial components of a problem, but a process to fix it. Thank you.
First thing I would say is, again, where we're trying to build out to is, when we talk about the diseases of despair, it's where does that despair start? So we're incredibly appreciative of the role that the social determinants of health play in this, that we know that in St. Louis City we have a very high mortality rate. We also know we have zip codes that are contiguous in this city in which the average lifespan is 30 years to 35 years more in one zip code than the other. So certainly it is a very holistic approach, which is why we have the entire cabinet working on that, from which these problems arise for that population or those populations. So that's the first thing. But again, I think what we're trying to build out is a medical home model of primary care doctors. As you know, Larry and I were talking, ER physicians and medical examiners are incredibly powerful advocates for the need to do things upstream, because you see on a daily basis the results, the sequela of what's happening that I would not have seen as a private practice OBGYN. And so I would encourage you, like Larry's doing, is to get very active in public policy, because you have a very powerful voice. You're on the front lines.
So I want to just say thank you again. My name's Kate Tansey. I work with United Way and have been a social worker, so thank you for all the good things you say about social workers. I'm going to spread the word. You guys are awesome. But also, so I've provided services, mental health services, and for the last 29 years in our nonprofit community. And now I work with United Way, and I help raise resources for that nonprofit community. And, you know, we do need that ecosystem, the ecosystem, excuse me. We can't, one program in itself is going to be ineffective. So what I'm really excited, and here's the hope piece, is that with this project, we'll really understand how to get better about treating things. That, yeah, you just don't call the treatment center if you can go get the medicine and then see a therapist to get the behavioral health piece. There's other ways to get this done, and I'm thinking we're figuring that out. United Way funds an awful lot of the organizations, thanks to really kind people like you, that donate to these organizations that really build out that ecosystem. So there is hope, and you are living proof. Thank you.
Just one last thing I do want to add, building on Representative Rader and Rachel's initiatives. We are having 8 summits around the state. We've already had one down in Springfield that had 500 people, very similar to this, engaging people from the community to find community responses. And we will be introducing a bill in the 2018 legislature for a needle exchange program statewide in Missouri. So again, we are pretty much defined as having a bias to action. We feel very strongly that when we have these problems, as Rachel said, with harm reduction, that our mantra is to save lives and change lives for the better, and we think that needle exchange program meets those 2 criteria.
I'm telling you guys right now, 100%, if someone comes in from an overdose or they're in trouble, maybe not overdosed yet, their brain isn't thinking about anything but getting out of there once their brain's back and doing that again. I know that I would search for the dealer who killed people because I knew it was the most potent and the best, okay? That's not a normal thought. So to me, when you go into, if someone's in an emergency room with you and you can talk to them and get the Suboxone in their system, that will instantly do something, instantly. And it might give you a window, just a little bitty window, to put hope into them. And, you know, you can change someone's life. You can change a lot of people's lives.